Moral courage and nursing leadership is our episode topic. Rejoining us as guest for this episode is Dr. Lisa Wolf, Director of Emergency Nursing Research at the Emergency Nurses Association and a fellow in both the Academy of Emergency Nursing and the American Academy of Nursing. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Shimolewski.
Lisa, thank you so much for joining us again.
Glad to be here.
All right, so I was listening to another podcast channel. I'm an active listener on it. The title of it, I'm going to put a plug in for it. The title of it is How to Not Kill Your Patient. I think I got that right. That
Yes.
You and Kevin McFarland are on, and more geared probably for frontline staff than for the audience of this podcast. But you were doing a talk on moral courage, and I thought, how does moral courage apply to nurse leaders and nurse executives? So let's explore that concept a little bit and start with, what is moral courage?
Yeah. So moral courage is an action, right? I think a lot of people think, oh, I would always act with moral courage, right? But it's an action, and it's an action that takes place when there is some risk to the actor, right? Doing the right thing is not morally courageous, right? That's just what you're supposed to do. What moral courage falls into is a place where you're putting yourself at risk. And that's not necessarily physical, but social, financial, structural risks that you are taking by speaking up or acting in the best interest of a patient, a system, a colleague, whatever.
And you did a study recently regarding moral courage. Can you talk a little bit more about that?
Yeah, this kind of flows out of my initial dissertation work, which is now 14 years old. And I'll just give you a little description of that as we move into this idea of moral courage, right? So the dissertation that I did back in 2011 looked at the intersection of moral reasoning and clinical reasoning, right? So essentially, how does someone's moral orientation affect how they operationalize a clinical decision? And we're going the Wayback Machine to Kohlberg. There are three stages of moral development that we look at in children. And the earliest is this very self-oriented, if it's good for me, it's good, right? That's your 2, 3, 4-year-olds. Then you get to 10, 11, 12, where if I follow the rules, it's good. And then finally, you get to this very social justice orientation where the translation to nursing is, if it's good for my patient, it's good. And so the study that I did back in 2011 really looked at the impact of where people were in their moral orientation and how they evaluated different clinical scenarios. So what we find is that, as expected, the vast majority of people, and nurses are people, function at that rules-based level. So if I follow the rules, I'm doing something that's good. What that means is that the rules have to be really good, and that's where nurse leaders come in. You have to set a unit tone, right? A moral environment in which it is important and appropriate to act in the best interests of patients, whether or not that kind of pushes up against other things. So that's that. So taking that as the idea, right? Most people go by rules. How are we going to apply that idea to a larger picture? The study that I did with Hannah Noblewolf was a study that came out of work that we had been doing, looking at how emergency nurses manage obstetric care in states with abortion bans. And in that first study, which was published in 2023 in the Journal of Emergency Nursing, we asked people, what would you do? And they all insisted I would take care of my patient. So then we had the question, So what does that actually mean? We can say that's the thought, that's the moral courage thought. But what's the action of moral courage? And so we did this study that we're going to talk about right now. We administered the nurses' moral courage scale, which comes out of Finland, to
I didn't know
75.
that even existed.
I know there's a tool for everything. This is a self-report tool, of course, right? And
Okay.
self-report is unsurprisingly 9 out of 10 of our respondents responded that on a scale of 1 to 10, they would respond with 10 out of 10 moral courage. And then, and what they said was like, it's very easy to justify a moral decision or a moral action to really people below me, right? Techs, patients, families, visitors, right? People below me on the medical hierarchy. Where things became really challenging is pushing back against physicians and administrators, is what they told us. So then, to get a bigger picture, we interviewed 10% of the sample. We interviewed 8 people. So the finding in the study that really prompted the interviews was we asked people, if you came across a situation that was morally distressing or ethically untenable, what action would you take? And the options were, I would bring it up for discussion, I would report it internally, or I would report it externally, be a whistleblower. And 2/3 of the people said, I would bring it up for discussion.
So just a question about that. That's a multiple choice question. And as
Yes.
I was listening to you talking about it on the other podcast, I was thinking, where would I fall in this line? And to be honest, I would start with, I would bring it up for internal discussion, but
Hmm.
I would also like to think
Escalate.
I would escalate. Was escalation an option in that multiple choice of, I'm going to start here, and if I don't get the result that is appropriate, then I'm going to move up to the next level? Or was it framed of a, what is as far as you're willing to go? Does that make
Exactly right. And that is always the why we want to do mixed methods, right? Because now here we have a question who 2/3 of the people answered, oh, I would bring it up for discussion. Now, to be fair, in some places, bringing something up for discussion is an act of moral courage.
which is
Um,
scary in and of itself, but
exactly. But so we wanted to explore that more, which is why we did the interviews. And
okay.
so we asked people, would you act? What would your action be? Why would you take that action? And why would you not take a different action? Right? Is really the overarching thing that we were looking at. And so what we found some very interesting things. One, even though 91% of our people said they had taken an ethics class, they didn't understand that professional ethics were something outside of themselves, right? They looked at professional ethics as a series of policies, right? Not as the overarching disciplinary structure, which was a little concerning to me, right? And we were talking to nurse leaders as well as staff nurses, right? Like we had a pretty decent sample. And so that's a little concerning that people don't understand that the reason we have professional ethics is because they supersede your personal ethics. If they align, that's awesome, right? But what people told us was that I would not act unless I was very personally invested, right? Not because from a disciplinary perspective, it's the correct thing to do. And or I would remind the nurse leaders listening to this is that when you sign on, you adhere to the ANA Code of Ethics. It is a duty driven code of ethics. You must do these things. It's not if I feel like it today, right? Or, oh, if it doesn't harm my bottom line, right? This is a series of professional ethics to which you are bound, right? And especially from a legal standpoint, I work a little bit as a legal expert, content expert sometimes, and I say, the code of ethics says you should have done this. Why did you not do that? Which always makes people squirm a little bit. But it's not just like a nice thing that we post every once in a while. It is the thing to which you are bound as a professional nurse. So there's that. The second thing that we found is that the barriers to morally correct action were social and financial. And I get people are absolutely in the position where doing the right thing from a disciplinary perspective could cost them their job, right? Many nurses are the sole breadwinners for their family. It is not fair to condemn people for not acting when it puts them out of a job. And this is again where nurse leaders come in. But the social barriers I've written about this a lot, is that the social environment, particularly of an emergency department, but any unit, really changes people's willingness to act, right? In a supportive moral environment, a supportive ethical environment where everybody's on the same page, we do what we do for the good of the patient, then people bring up things that aren't good. People call out providers and colleagues who are acting in a way that is not ethical from the perspective of patient good, right? And in places where those things are suppressed or not considered important, then there's a lot more hesitancy to call out those types of behaviors.
It makes me think about, and unfortunately, I was trying to look it up on YouTube earlier this week for something else I was working on, but it makes me think about a president address at ENA's General Assembly in 2014,
Mm,
10 years ago, maybe 11 years ago by the time this airs, that the then President Dina Brescher said, and her entire talk was about you as a nurse set the tone of what is permitted and what is not permitted in your department. And so wanted to maybe explore that concept a little bit further because our audience is nurse leaders and nurse executives, but yet at the same point in time, we need to realize that at the end of the day, the tone of what's permitted and what's not is really more of a cultural issue. And
absolutely.
so those two things are somewhat in tension with one another.
Mm,
And as a leader, as an executive, how can I help influence and set an environment by which holding one another accountable is permissible, it is expected, and not only asking the staff to hold each other accountable, but inviting an environment where, to an appropriate professionalism extent, the staff are able to hold their leaders
mhm.
accountable. And what does that look like?
Yeah, it's a great question. It's the $1,000,000 question. I think there is definitely tension in the ethical expectations of the discipline versus the very practical reality of running a healthcare institution, unit, whatever. However, in a lot of ways, doing the right thing is always less expensive than doing the wrong thing.
Say
And
more about that.
I think if you look, let's think just I'm just going to throw out there the idea of staffing, right?
Yeah.
So if you need, let's say you need 12 nurses on a shift for when you're to have an appropriate care environment, right? So you need 12 nurses on a shift, but you don't have the budget for 12 nurses on the shift. So you hire 9 nurses for the shift and you rely on those 9 nurses to either fill in with overtime, which is more expensive than straight time, or travelers, which are gargantuanly more expensive than regular nurses. Plus, you get people who are working in an environment that is not conducive to good work, in that they are stressed out, burned out, working too many hours, and they leave. They start taking sick days, they start taking mental health days because they need them. And now you've got to account for that staff loss. When if you just hired 12 nurses, didn't require them to do overtime, and kept things humming, you'd have less burnout, you'd have a better working environment, and people would stay.
That's a fair point. It also assumes that there are 12 nurses out there that are available because sometimes it's difficult to find
Sure,
qualified staff.
exactly right. But
Yeah.
the perspective is that we need this number of people, not we
Okay.
don't have the budget for this number of people. Those are two different problems,
Okay. Fair enough.
right?
Yeah.
So, in that sense, and similarly, do we have enough ancillary staff so that the nurses can devote their brain power and their training to patient assessment and decision making, right? So there's all kinds of very small ways. I tell my students every nursing decision is an ethical decision. The decision to leave a patient to go to another patient is an ethical decision. Am I making the right choice for this patient because the patient is stable? Or am I making the right choice for me because I'm tired of taking care of this patient and I got to go take care of this other person, right? Do I go to lunch or do I take that other set of vital signs? Do I approach my patient who is in pain with derision or dismissal, or do I approach them from a position of my job is to make you as comfortable as I possibly can on this a really bad day for you, right? So even just like what we would think of as like attitude can really have ethical implications. So when we have this sort of dispositional bias, right? Basically, I'm having a bad day, so everybody else is here to make my life difficult, and I'm going to treat them thusly. That is not just an error in communication. That is also sets you up to make some very bad practice and therefore ethical choices. What nurse leaders can model and can support is a working environment, which, by the way, is provision 6 of the ANA Code of Ethics, that institutions provide safe and healthy working environments that are conducive to good patient care, um, to best allow people to have a good day at work, right? Which in turn benefits the patients they care for.
So what
Does
does
that
that
make sense?
yeah, what does that really look like in Provision 6? I understand what the words mean, but
Right,
okay, I'm in a leadership role and I'm reading this. How do I operationalize that
right,
or set forth the structure from which that may operate?
right. So a lot of that is, I think, setting up things like, okay, just from minutia, right? I'm going to give
Yeah.
you all the minutia. Thing one, keep your older nurses, your experienced nurses trained and not burnt out, right? Because they're going to be the people who train your newer nurses. And the older nurses, the more experienced nurses, are going to train the new nurses dependent on how they're feeling about their own jobs. So if I love my job, the way I train a new person is going to reflect that. And hopefully they will also love their job. If I hate my job and can't wait to leave, I am going to train that next nurse to hate everything about this job, right? Because I'm just telling them we should be doing this, but this is the workaround because we don't have enough of this or that, or we don't, I've worked 6 days in a row and you're going to do that too, right? You've heard this.
Yeah.
So that environment is crucial, right? And I think overlooked as we think about how do we set up an environment where people are supportive of each other, right? What's the tenor in your department around bullying, right? Bullying has two pieces to it. And I think we really consider it more like the acts of overt bullying, right? The yelling, the dismissiveness, the eye rolling, stuff like that. Yes, that's there. But what is more damaging is an environment in which people withdraw. They withdraw information, they withdraw help. They're like, oh, I'm sorry. And it's really hard to pin down if you're a nurse leader because I haven't done anything to new nurse. I was busy with my patient. I couldn't possibly have helped her deal with that crashing patient because I was busy over here. It's that kind of unit violence which causes your new nurses to leave. And now the tone is set because now we know the behaviors that are going to continue. And I think what's really challenging for nurse leaders is to challenge those behaviors and make that unacceptable. Now, why is this an act of moral courage? Because if you confront Nurse Jane, who's been there for 30 years, and Nurse Jane is mad at you, that's the fear. Nurse Jane will be mad at me. She'll leave. She'll sabotage me in some way. That's entirely possible. But you're the boss. I think you
Yeah.
actually have things at your disposal to mitigate. But it's that fear that somebody's going to be mad at me or socially unpleasant that actually is a huge barrier to moral courage. And this is how it can fit in from the leadership perspective is that we're afraid our nurses will be mad at us and in some ways sabotage the work of the unit, right? Which is not entirely unreasonable, right? Because it happens. But we find in our work on bullying, as well as in our work on bias, is that the only way to stop that behavior is to call it out, to address it. It doesn't just go away. It only gets worse. So from the perspective that your moral obligation as a nursing leader is to create a unit culture in which nurses are supportive, helpful, and hold each other accountable in the best possible way, you have to address these other behaviors and the conditions under which those behaviors occur.
We've talked so far about, and really from the staff perspective, when we talk about moral courage, it's more about courage about what a higher level of authority and the repercussions of acting with moral courage would be. So far in our
Mhm.
conversation about nurse leaders, it's been more about how do we set the tone for the department down. Can we talk about some examples about what moral courage as a nurse leader or a nurse executive looks like when we're looking up to that next level of authority?
But it looks like
maybe
talking to the CNO or talking to people up
talking to
there.
the CNO, or if you're the CNO, you're talking to the president or the board, or maybe even perhaps regulators that are in your facility when issues come up.
Right. From that perspective, again, keeping in mind that the professional code of ethics is a duty driven set of expectations. And I think this is what I try to give like my students who are nurse leaders in their work, and that is a vocabulary to speak about these things in ways that don't come off as like a personal grievance or a personal preference, but as a disciplinary code of ethics, right? So we have to think about issues, right? Deontological, ethical issues of beneficence, right? The good, right? And in this case, that means the good for the patient. The second is non maleficence, which is doing no harm. The third is fidelity, keeping promises. So, in other words, if you are an institution, especially if you are a local institution, the promise that you give to the community you serve is that you will take care of them. And that is an ethical principle. And if care is substandard for whatever reason, you are violating that ethical principle of fidelity. And similarly, there is the principle of veracity, right? Telling the truth. And so when things happen in your hospital that are perhaps unexpected and cause harm, the principle of veracity requires that be openly discussed and amends are made. And then the last thing that I want to talk about is the principle of justice, which really talks about equity and access. And so making care accessible to your entire community is an ethical principle. And so these are the things that are violated when we create an environment in which those things can't happen, right? But it is the language of ethics that takes the problem from I, individual person, am upset about this to disciplinary duty that we are violating, which is a bigger, I think, more compelling argument for a lot of CNOs and other high level administrators.
I think frontline staff, it's reasonable to, no, not reasonable. It should be expected that frontline staff are operating from a deontological perspective when it comes to patient care. Where
Mhm.
my question is going on this is,
You can't be a utilitarianism. You
I,
can't be a utilitarianist. No.
I get that you can't do that as a frontline staff member, but let's talk about that tension that exists then as an executive, because deontological is literally every patient, right? Whereas from a
Right.
utilitarian perspective, it's like you have hundreds or thousands of patients. How,
Mhm.
w- w- where do you operate and what does it look like?
Right.
How do I operate from a deontological perspective when I'm an executive and I'm taking care of 1,000 patients or
Sure.
thousands of patients? Does that make
And
sense?
I think, yeah, I think the greatest good for the greatest number is both a public health approach, and we use that actually that idea of utilitarianism to constrain people's behavior. In other words, I understand that as an individual, you are an individual nurse, for example, right? You are an autonomous being and you can make decisions about your body. However, in this public health situation, we need to maintain the greatest good for all of our patients, and therefore we will require you to get a flu vaccine, get a COVID vaccine, be vaccinated against Hep B, because our duty to our patients supersedes your personal autonomous need. And you're also free to not work there, right? So that's how utilitarianism gets played out in more public health settings. It is used as a mechanism to explain constraints on particular behaviors. But if you're going to say, we took care of most everybody, now you need to really think about who are the people who are not getting care, right? And how is that justifiable, right? From a professional ethical standpoint. Does that make sense?
It does. And then I start thinking about taking it down to, and again, our experiences are the ED. I'm sure there are other experiences in other care areas. You have your triage categories of ESI 1, 2, 3, 4, and 5. And so from a deontological perspective, it would just be like, listen, I'm going to take care of the patients as they come in. But really from a utilitarianism perspective, which is really somewhat what ESI is around, which is we want to make sure that anyone that's dying is not going to die. And that may mean that a lower acuity patient is going to wait for a longer period of time because they can wait.
We're not violating any ethical principles there because
Fair point.
if I determine that you do not need immediate care, I am not obliged to give you immediate care. It's not a bakery,
Okay. Okay.
right?
Yeah.
If I determine that you are in need of immediate care and I deny it to you because I'm going to take this blue elbow because they've been waiting longer, that's a violation. That's an ethical violation. Not that I make blue elbow wait for an hour while I take care of coding guy.
So while we're on the topic and we're on the topic of ethics, talk to me about your thoughts about care delivery for, thinking of the right words to say this, for one of our own, such
Mhm.
as a staff member in the department,
Like VIP care.
or yeah, and your thoughts on VIP care organizationally as a principle, because there are a lot of organizations out there that are doing that. And
That
so
is a
both from a,
violation of the principle of justice.
okay.
That's all there is to it, right?
And
You
I agree.
are
I'm just,
Yeah,
just,
that's an ethical violation.
yeah.
Absolutely, 100%. It's great customer service if the person's gonna give you $1,000,000, but it's not ethical at all.
Well, and forget donors for a minute. Let's just even talk about other caregivers. You have a nurse that gets injured up on the floor and they're now coming down to the ED, and you're prioritizing that care over the care of someone else.
Yeah, I think we tend to take care of our own, as a professional courtesy, but that's all it is. It's a professional courtesy, when you can, right? Like, there's queue jumping that is really unethical, and there's for example, I would say it's completely ethical to take a nurse who has experienced a needle stick on the floor.
They're an ESI2 by
They're an
definition
ESI
anyways.
too, absolutely. So you're
So,
not queue jumping at all. You're providing appropriate care.
but a sprained
Um,
ankle or an injured back,
right. Exactly right.
okay. Well, one of the things you talked about much earlier in the podcast was a lack of knowledge. Everyone went through an ethics class. That information was not necessarily retained over the years. Hey, I'm a nurse leader and I've read your study, which, by the way, is very eye opening and scary to read. And I'm going, okay, I want to do something about this. What
Mhm.
would your recommendations be around bridging that knowledge gap for those that likely exist within their sphere of their organization?
Yeah, I think ethics rounds are a great idea,
Tell me more about
right?
that.
And like there were like they used to do Schwartz rounds, which originated, I think, out of the Brigham.
About the movie Spaceballs when I hear
Exactly.
so I don't
But what you can do is at a staff meeting, for example, you present a short case, right?
okay.
It's something about maybe even start with the idea of VIP care, right? Or something else. And then at the staff meeting, we're like, what are the issues with this? Or are there issues? Is this fine? For example, so I have a patient, you have a patient who comes to triage, for example, right? Or lands in your bed. And this is a patient who has fallen and injured themselves, but you also know that this patient has a history of substance use disorder, right? What is the ethical way to proceed in the care of this patient? Because what will happen a lot of the time is the nurse or other provider will decide that this patient is merely there to obtain drugs. And they will dismiss their symptoms and dismiss their concerns and not medicate them because they're just here for something. And talking through like why that is an enormous like, clinical mistake, first of all, but why also is that an ethical violation? And just have people think about these principles and the duty to care in ways that perhaps they haven't really thought about. You can do that very quickly. You can take half an hour of a monthly staff meeting or a quarterly staff meeting. You can post them up. You can, I would not suggest like Health Stream or something because people never read those things anyway. They just click through them. But the idea that these are not personal preferences, these are actual professional obligations that we really need to reckon with in a way in an environment that's never clear cut, right? It's never black and white. Rarely. It's rarely black and white. There's a lot of nuance and people bring a lot of stuff to the party, as it were, that can cloud ethical judgment. And when our ethical judgment is a little off, our clinical decision making flows from that in a lot of ways. And we can be providing not great care because we're not thinking about this as an ethical problem,
Anything
right?
we didn't talk about on the episode today that you wanted to talk about?
I think nursing leaders are in a really challenging position because a lot of them come out of the trenches with the goal of doing better. And it's so hard because they keep bumping up against all these barriers. that they have no control over. So it's a really ethically challenging environment in which to work. And I think having the language of ethics to construct an argument against what is happening is really valuable.
Yeah, it's probably not being used to frame the conversations that need to be had. And that's where you start, right? And from a
Right.
structure perspective, Don Abedian guy again, right? So
Right.
start from the structure of framing it within the construct of ethics, and maybe that will achieve better outcomes.
It gets people thinking a little more, right?
Yeah.
This is bad is very different than this is ethically bereft, right? This is absolutely unethical because people in institutions can stand up against, well, you made some bad decisions, but to fight against the label of unethical, it's different.
Cool.
It lands differently
Any closing thoughts as we wrap up this episode?
because the vast majority of people work from a rules-based orientation. It's really important that the rules are good. And so it's really the obligation and good work of nurse leaders to set environments in which ethical work can happen.
Lisa, what's the name of that article again that you wrote that every nurse leader should go take a look at?
Oh, it's called Moral Courage in Emergency Nurses in States with Abortion Bans. That's in Nursing Ethics. And then the dissertation study, which is published in the International Journal of Nursing Knowledge, is Integrated Ethically Driven Model of Clinical Decision Making. And that really talks about this idea of the individual, the unit, and the administrative environment.
Practicing moral courage for nurse leaders has been our episode topic. Dr. Lisa Wolf, thank you so much for your time today.
Thanks a lot.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.